All right, welcome to Pediatric Emergencies. Let me tell you guys, this is a long lecture. I'm going to break this up into as many digestible parts as I possibly can, but understand that throughout this entire book, the majority of what we're dealing with is trying to teach you the adult population and their emergencies. And that's specifically due to the fact that, for the most part, children generally don't suffer from that many ailments, and really some of their bigger problems is unintended trauma. So we're going to dive into this because some of these things are really going to need to stay with you for the rest of your career, because we can't treat pediatrics like miniature adults is kind of the gist of where we're going with this one. So try to buckle in and stay tuned, because we want to make sure that you get all the information that you can possibly get and start categorizing it in the appropriate places. If at any point in time you become confused about this, please do reach out to me and we'll see if we can clear up some of these topics. As promised, special patient populations, the fundamental knowledge of growth, development, aging, and assessment findings provide basic and selected advanced emergency care and transportation for a patient with special needs. So this is a completely different kind of scenario than your typical adult. So we want to make sure that you have that fundamental knowledge, right? We're not asking you to be a pediatrician, but you do need to understand some of the very significant differences between a pediatric patient and an adult patient. We're looking at the age-related assessment findings and the differences between them. And we really want everyone to know that the airway is a significant problem in pediatrics because of the diameter or the lumen size of the actual main airway. A small reduction in size is a significant reduction in ventilatory ability. We're going to go through respiratory distress, shock, seizures, sudden infant death syndrome, GI diseases, and then we'll get into some special challenges. And regarding that, that's going to be your child abuse and neglect, because that is a must report situation for EMS, right? That's actually a must report for anybody. If you suspect child abuse or neglect, most states have that in law that you have to actually report that. So we're looking at the abuse, neglect, homelessness, and significant poverty. We want to make sure that you actually understand the differences in trauma and the assessment findings and the appropriate care and management for pediatrics. In some medications, your drug dosing is going to be different than an adult, and we want you to understand some of the basic core fundamentals in regards to signs of shock, especially considering trauma. All right, so into the introduction. Pediatric emergencies account for a relatively small percentage of the EMS system's call volume, and this is true. This is in any service that I've worked in. It's single digits for the percentage-wise. More often than not, you're going to get a lot of brand new parents who are calling 911 for sick children, and then really the bulk of it after that point is going to be made up by unintended trauma. And so as the slide says, it's not uncommon to experience a little anxiety when you're responding to that call. These are the calls that we want to train for, but really never kind of receive. So this is kind of one of those high risk, low frequency events. And this is why we should always try to stay brushed up on our actual pediatric medicine, because of the low occurrence that we kind of run into these things. It's really easy to start shuffling this information out of your head and then get behind the 8 ball when you're trying to treat a patient who really needs your help. Be prepared to deal with the parents or the caregivers. Everybody in the pediatric event is generally going to be a little out of shape emotionally, right? This is something that we don't normally see, especially the layperson or the immediate family members who are very worried about a young child or a younger patient who's going to have some kind of significant injury or illness. They're going to really need to kind of have you stay focused, and that you're going to end up showing that you have the calmness and the kind of stoicism that's needed to make good logical decisions. So in regards to this slide that's saying you may have multiple patients that you're going to have to treat, that's not necessarily like actual treating them, right? You're going to treat them emotionally and psychologically because they're going to need a little bit of support. They need to understand that you're going to do the best that you can to get them the appropriate treatment while they're in your care, and you're going to get them to the appropriate place for continued treatment after you've kind of done that handoff. So a calm parent will help you in every facet of what's going on. When a small child sees that their parent is upset and kind of spun out of control, so to speak, that child is going to become nervous themselves, much like your partners are. If you're the highest trained person on scene and you're not in control and you can't keep yourself calm, everybody with less training is going to suddenly become full of anxiety as well. All right, so we're going to talk about a few definitions. In the last lecture, we talked about neonates and the OB kind of scenario world, and then now we're going to talk about infancy. This is that first year of life. Remember that neonate or newborn is the first month after the child has actually been delivered. In those first 2 months of being an infant, they spend most of their time sleeping or eating. There's a lot of growth that's going on. If you've ever watched a child kind of grow in their first year of life, within the first year, they're going to double in weight. So they're spending an extraordinary amount of time feeding and staying in a rested rate because their body is producing so many cells to create this exponential growth. They're really kind of responsive mostly to physical stimuli. They'll respond to sudden or intense light, some additional warmth, hunger, and sound, and they have a real hard time kind of communicating, right? And this is where a lot of parents become frustrated because their children are still kind of unable to actually give them different cries about the things that they need. So the infants are pretty easily aroused from the sleeping state. That's usually because they're going to go into a feeding mode or being cleaned. Their head control is really limited because they have such a large kind of head in comparison to the rest of the body. Their neck muscles are not fully formed in regards to actually having the enough strength to support the weight of the head. They are very predisposed to hypothermia, and that's because of the muscle tone really isn't where it needs to be yet, and they have a hard time kind of shivering and trying to keep themselves to where they're actually thermoregulated. Their crying, again, is that main mode of expression, and as they're really, really small, it's kind of hard, or I should say difficult, for parents, especially anybody outside of the immediate family, to really understand the different cries that a baby may have in regards to them trying to express what they actually need or want, whether that's food, warmth, comfort, or to be cleaned. As we get a little bit longer into the infancy, this is the 2 to 6 months, they're spending a little bit more time awake. They really still don't have great visual perception yet, and they're a little more active and they're social. They're starting to very easily cue into mom or dad's voice, and although they haven't really kind of grasped their sense of self or that they should be intimidated by strangers, these are things that are starting to kind of pair bond with the parents. They can recognize the caregivers. They know who the normal people are that are in and outside of their daily operations or their daily routines, and they will voluntarily or reflexively smile and increase their eye contact as this time's kind of coming up. By 4 months, infants are able to hold their heads up on their own, and this is where you see babies kind of starting to prop themselves up, and they can kind of keep their head in a stationary plane. Healthy infants will have a strong sucking reflex. They have very active extremity movement, so you can kind of push against their feet. They'll kind of kick back. You can ply them around a little bit. They are very vigorous criers. If you don't have children or you've never had children, this is when they start becoming extremely vocal, letting you know that there's something that they want or need. If you have a child at this point where they're lacking eye contact, this can be a sign of significant illness, right? This is where we would typically say that we have a lethargic baby who is non-interactive with the exterior environment, and these are telltale cues that let us know that there's some kind of altered mentation as appropriate for the age of the child. At about 6 to 12 months, they can kind of sit upright unsupported. They're able to actually upright themselves. They're reaching for things, they're crawling around, and some children by 12 months are actually up and starting to make their initial walking, or can get across a room walking. This is when we're starting to get into that danger zone, because we've got children that are highly mobile, and if you're not putting things away, or the parents aren't putting things away or keeping them out of reach, it seems that everything that you don't want a child to have, they're going to find. They're starting to teeth, and they're really testing most of their environment with their mouth. This is kind of a natural phenomenon, and also part of the teething process where they're trying to cut through the gum. But a lot of children use their mouths to explore a lot of their external environment. They're also beginning to babble. This is where they're attempting to mimic sounds, and by that first year, we're hoping that for the most part, if there's no cognitive delay or any kind of hearing problems, that children are able to mimic and actually repeat words back to you. This is where they're picking up mom or dad or mama or dada, or any of those other short, easily communicated, single to 2 syllable words. This is where they will also, because of that longer term pair bonding with the parents, they may actually start to cry. They become aware of a stranger, and that there's somebody who maybe smells different and looks different and has a different sound. And while they're not necessarily shy, they've started to psychologically develop that dependence on parents, because they recognize them as the protector and the provider. Now we're going to get a little deeper into the pediatric assessment triangle in a little bit, but just understand that this is work of breathing, circulation, and their appearance, their general appearance. And for the most part, this is almost what all EMTs, especially most of the medics, are going to tell you, that when we walk in and we're dealing with children, this is kind of that primary assessment for us, and we're looking for things that are very specific, because their respiratory pattern is going to be mildly different than an adult, which will throw you off your initial assessment. So we're really looking for that work of breathing, whether or not they're mentating appropriately, and then like how they actually look in regards to skin turgor or their circulatory. We're looking for that skin color and things like that. The parents or the caregivers who spend an extraordinary amount of time with the child are going to be the ones that are able to tell you that, hey, something's not right. You may not pick up on that cue right now, because you just don't know that child. We don't know if that's pale for them or if they're just generally pale. And so make sure that if there's a non-specific concern about a young child's behavior or an infant, that should be a tip-off, that because somebody who spends a significant amount of time with them kind of sees this, that we're a little early in a problem, and we want to make sure that we're getting that looked at. So as this slide says, by 6 months, babies should be able to make eye contact with you when you're trying to do that. Again, if they're lacking eye contact, that can be some kind of significant illness, or what we would call like a malaise. And infants approaching right around the year mark are very much at risk for that foreign body aspiration. If you remember what I just said, when they get up and they're crawling and walking, it's really, really hard for a lot of people to kind of assess the scene, so to speak, which is everything that's in the house. If it's small and loose and they can pick it up and get it into their mouth, chances are it's going to get into their mouth, and then we get those unintended foreign body obstructions, or we can get something as kind of severe as a poisoning, which would be an unintended thing. And we'll talk a little bit more about that later on in the lecture, and this is where they get into adult medications, and some of these can be really, really nasty. Now in this slide, we're talking about being opportunistic, right? And this is like coming in and strategizing when you're dealing with a child. You never really know what the reaction is going to be. And so in this particular slide, we're talking about if the child's quiet still, we don't have a baby that's crying. This is probably your time to kind of warm the bell of your stethoscope up, and you want to listen to the heart and lungs before they start crying. It's really hard to kind of hear what's going on. I will tell you that a crying baby will still have those adventitious lung sounds, but now you're really kind of having to sort through all these different noises as you're listening, trying to kind of perhaps ignore like the actual vocal crying. If you have a baby that starts to cry, see if one of the parents has something that could distract the baby, or give something to kind of comfort the baby, such as the pacifier. I'm not a big fan of us putting gloved fingers in the baby's mouth unless this is something that we really, really have to. Again, the gloves are there to protect you and to protect your patient from transferring any kind of pathogen or disease process. And we're not wearing gloves that are very sterile or anything like that. And so we don't want to willingly or intentionally put our fingers in their mouth. When we're talking about toddlers, we're talking about children that are 1 to 3 years of age. Now, these are significantly more developed at this point. They should be up and walking and talking. While they don't have a great vocabulary, they are able to communicate with you. The injuries are going to increase because this is when they're very curious. They're trying to figure out their external environment and they're mobile. Let me stress upon you again that once children become mobile, this is when trauma starts to happen. There's a much more higher likelihood or percentage rate of unintended trauma as soon as these children are up and moving around, and parents maybe lose track of them for 15, 20 seconds. Now this toddler's kind of scooted across the living room, is in the kitchen, and finding some kind of object to create some kind of havoc with themselves. They will start often imitating older children or parents because they're learning by watching them and observing and imitating. And if you talk to them as, probably a little bit older, right? Not at about 1, maybe 2 to 3 years of age. If you say, show me your arm, they'll actually pick their arm up. You can tell them, point to their head, and they'll actually show you, that particular body part. They're becoming very aware of themselves and their spatial surroundings. So as I'm kind of alluding to a little bit earlier, the mind is developing rapidly. They're able to name a common object that you point to, and this is right around that 2-year mark. They understand some cause and effect, and this is very easily figured out by watching a child that likes to play peekaboo, or they throw an object off the table for you to return it. And this is where they learn when things go away that they can come back, and sometimes if they go away, they never come back. Their balance is steadily improving. By around 2 to 3 years of age, most children are walking without any assistance at all and can get a pretty good distance without tiring out. So as far as I'm going to go with this slide is the persistent crying and irritability can be a symptom of serious illness. Again, think about a toddler. They're able to talk. They have basic core concepts down. They will communicate with you, and they can kind of give you a small idea of what's happening, but their vocabulary just isn't there yet. So they can often revert to just being really what we would call fussy, and you'll get to where they're kind of crying or very irritable for what you would consider no reason. And that's simply because that's their way of communicating. They're going to revert back to their easiest form of communication if they don't have the vocabulary to express their need. Now, when we're talking about doing a physical examination, as the slide says, we're wanting the parent to comfort this child. Children that are around 2 to 3 years of age have now become self-aware. They understand that they are an individual, and they will often start to become shy. This is where kids will kind of duck behind mom and dad if they're healthy and they're not really interactive with strangers. And so you want mom or dad or whatever caregiver is there that's the child is comfortable with to kind of comfort them and keep them still while you're trying to get your assessment done. And then you want to make sure that you're trying to make yourself as small and unintimidating as possible with the child. As you can see here, the EMT is kind of on a bended knee. She's low and she's letting the child explore the stethoscope. And this is so that we can kind of get them moving along with us and not be intimidated by things that they don't know or understand yet. And another little subtle clue in this picture is that the child has a book, and this is to serve as a distraction from what we're trying to do. We want to try to be creative. We're trying to get them to kind of buy into what we're doing without forcing it on them, right? Because if we're forcing an examination on a toddler, they're really going to start kind of pushing back. They're going to rebel a little bit, and this is mostly out of anxiety. It's not like a malicious intent. So have the parents kind of help you with the assessment and figure out like where they're hurting, or if we can get that stethoscope on them. Use some play and distraction whenever you can. Often in most ambulances, we're carrying small stuffed animals, and a new toy is usually a great distraction. And anytime that we have something that's going to upset or cause any kind of physical disturbance, such as a glucometer stick, or if we're going to perform some kind of IV access, make that one of the last things that you're doing when you have a child that's still able to interact with you and is not so ill that they're lethargic.